In this lecture, I would like to discuss the physical therapy management of medical screening for the lumbar spine. My name is Leda McDaniel. I'm a physical therapist currently practicing in an outpatient orthopedic setting, and that is my reference point. I will discuss screening in diverse settings, but that is the point which I am accessing patient care in physical therapy. Okay, so objectives for this lecture, I want to briefly review best practices for managing acute low back pain. I want to discuss common screening methods for serious spinal pathology, the use of red flag screening, discuss the use of a decision tool that might guide clinical decisions in our screening, identify serious spinal pathologies and the signs and symptoms that are common to those pathologies so we can start thinking about if we are picking up on red flags or if we do suspect underlying spinal pathology. We're not making the medical diagnosis for that pathology, but we do want to have those medical diagnoses in mind that may correspond with these clusters of signs and symptoms. And we want to practice medical screening with patient cases. So trying to apply these principles to example patients that we might see in our physical therapy practices. So first off, what are best practices for acute onset low back pain? Well, given recent clinical practice guidelines for physical therapy and for primary care treatment of low back pain, one of our best practices is to screen for red flags, which is a lot of what we will be talking about in this lecture, given that we're talking about screening. I think it is helpful, though, to talk about that screening within the context of what are some other best practices for low back pain, because I think screening fits into our greater model. And as we'll see, some of the red flags that we talk about and some of the management of patients, it always comes back to the context of what are we doing? Are we recommending treatment? Are we referring right away? A lot of times the decisions that we're making kind of fall somewhere in the middle where we're treating and maybe watchful waiting, monitoring progress, things like that. So assessing the way we screen and the way we deal with red flags and low back pain, I think, is only important or comes back to the clinical context of what our goals are. So our goals in treating these individuals with low back pain, assuming that we screen, we really want to assess, we want to perform our neuroscreen if radicular symptoms are present. We really want to assess comprehensively with our subjective and our objective examination, perform a really thorough exam. But if we don't find anything that's overly troublesome or suspicious of underlying more serious pathology, best practices suggest that individuals with low back pain return to work, return to activities. We engage them in discussions that this low back pain is not that serious. They have a favorable prognosis. They're likely going to get better over the course of time with minimal to no treatment. We can recommend some conservative care and really only use imaging if we suspect something serious underlying. We want to de-emphasize more invasive and riskier treatments such as surgery or heavier medications. And we always want to screen for yellow flags as well because we know those contribute to low back pain, so assessing for psychosocial factors. So what are red flags? Well, red flags are going to be signs and symptoms that raise a suspicion of something underlying that is more sinister or serious spinal pathology. We're talking about low back pain. And if we're utilizing these tools, we want to be asking ourselves, how good are these red flags? So recently there have been some critiques on the use of red flags as screening tools. So Cook et al. Did a narrative review in 2018, and they really critiqued the use of red flags. And they had a couple critiques. Some of these were that the red flags were not necessarily valid as screening tools. So with poor likelihood ratios, many of them were not useful to rule out these diagnoses that we were utilizing them to do. So that's a problem. They also mentioned that our clinical practice guidelines oftentimes name a high number of red flags for these different pathologies, 20 different red flags, 30 different red flags. Well, if we are to assess all those different flags or all those different signs and symptoms, is that really useful in helping us make clinical decisions and getting patients the care that they need? Maybe, maybe not. Maybe it's not the guide that we are looking for. They question the accuracy of those as well. So a lot of times the link of that red flag to the underlying pathology, not necessarily there. A couple other studies that are named on this slide, looking at, again, reviews of multiple studies and the utility of red flag screening questions the accuracy of these red flags. It also questions the support of their use for what we oftentimes call value-based care. So are those red flags guiding the use of what our CPGs are telling us to do with low back pain, which in many cases is to utilize conservative care and not use imaging? Well, if we're picking up on red flags and that drives us to use imaging, a lot of times that's costly and it could induce harmful effects. So nocebo effects where patients are overly concerned with what it says on their image. It's not necessarily correlating with our best practice clinical care for these patients. So anyway, there are some problems with red flags just as a concept, and we'll kind of go through that. So if we're not utilizing red flags, or if that's not the thing that we're hanging our hat on to screen within low back pain and try to figure out, is there something more serious that necessitates referral? What are we to do? Where do we go? So there's a 2020 position statement that came out in JOSPT that I think can be very helpful in giving us some guidance in this. And so this position statement was developed by the International Federation for Orthopedic Manipulative Physical Therapists, or IFOMT is the acronym. And it really tries to provide a framework for utilizing red flags and which are the most useful red flags to guide us in our treatment or our screening for serious spinal pathology. We'll kind of talk about some of the other recommendations that provide context for not only relying on red flags, but relying on other portions of our examination, risk factors, and it really helps guide decision-making is the ultimate goal, to utilize this as a decision tool for how we treat, triage, refer patients. And these are some of the key clinical messages from that position statement. I'm not going to read these to you, but just for your reference. And we're going to kind of distill these and work through these over the course of the next few slides and patient case examples. So coming back to the best practices for acute onset low back pain, we do want to screen for red flags, or we do want to screen for things that may indicate underlying pathology. If there are no red flags present in our examination, we're going to recommend these things that I was mentioning prior. So early return to activity, avoiding more invasive treatments, education on favorable prognosis, kind of treating symptoms in the least invasive way. No red flags. That's kind of the easy scenario, right? But we know a lot of times patients will fall closer to the middle of the spectrum. They might have one or two red flags. They might have lots of red flags. What do we do then if the red flags that we're seeing, we're unsure of their diagnostic accuracy, or we're unsure whether those indicate the patient has this disorder? Should we refer them to a specialist? Should we treat and refer? So there's a lot of gray area, or there are a lot of things that we need to consider in using these red flags and our screening process in low back pain or the lumbar spine. So again, coming back to the position paper, here are really the recommendations that I think can carry us through this decision-making process as we talk about screening in the lumbar spine. So we want to utilize not just one red flag, but multiple, and we want to use the ones with the best diagnostic accuracy to rule in, rule out this pathology, or to at least guide our decision making, whether we should refer for further testing. We want to perform a thorough exam. This is true for all of our physical therapy treatments, but we really want to do our due diligence and investigate and gather as much data as we can to make the best recommendations that we can. If we're suspicious of underlying pathology, these guidelines recommend two things within this gray area. a watchful waiting, and that's going to be on us as therapists to monitor patient response to treatment, symptom response to treatment. And we also want to recommend or utilize a safety net type process where we're educating the patient on symptoms that may indicate further deterioration or movement towards the likelihood of this serious pathology, and what to do if they're experiencing those things, where to go. Should they go to urgent care? Should they go to the ER? So those two things are going to be really helpful as we navigate some of that in between. And we really want to know our referral pathways. So we want to know who to go to before we need to utilize that. So that's kind of the pre-planning that we always want to be thinking about. Where is best to refer if we need to, if that means immediate or if that means we need to do that down the road. So here is kind of the upshot of the clinical reasoning pathway that's recommended in this framework. And this is a decision tool that I want to utilize to guide some of our decision making as we talk through patient cases. So the first thing that we want to do is assess the level of concern. That's going to be part of our screening. Secondly, is our clinical action. Do we treat? Is this patient appropriate for physical therapy, or do we want to refer them on to obtain further testing, to rule things in, rule things out, and so that they can get the best care that they need? And then third, we want to identify the appropriate referral pathway, as mentioned in the prior slide. So the first thing that is of utmost importance is to assess our level of concern. And this is really where screening comes into play, where we're trying to identify what factors from the patient history, what factors from our examination are concerning. So do we pick up on any concerning features that don't fit what we would think about for musculoskeletal mechanical low back pain? Is there anything that indicates underlying pathology where they would need treatment beyond physical therapy? So we kind of have these 4 stages. Low is green, not really indicating something serious. Yellow and orange, that's kind of our gray area, or where we're forced to utilize a little bit more of our clinical judgment and decision making. And then high, these things should be screaming at us for emergency referral. That patient is definitely inappropriate for physical therapy. We want to get them to emergent care right away. So this is another figure from the position statement article, and this is kind of a decision tree as somebody is referred with what we think is a musculoskeletal condition. And these different pathways, the green, we're going to treat in physical therapy. Yellow, we're going to kind of utilize the watchful wait, safety netting. We're not quite sure how they're going to respond, but we're still hopeful. And the red, we definitely want to get some more information. So with our clinical action, treating versus referring, how does that look? Well, digging into this model a little bit more, if, again, we have no concerning features, we're going to kind of, this is PT as usual. We're going to treat, we're assuming the patient's going to respond well. We do have the caveat that if they don't respond, we could reassess and possibly refer, but overall, we're assuming that this patient's going to respond to our care with a favorable prognosis. We don't really see concerning things in our initial exam. Yellow light is we're going to trial conservative care. We have a few things that kind of make us suspicious, but not enough to send that patient off for referral right away. We do want to take steps to initiate that referral, whether it's communicating back with our referral source. We definitely want to educate patients, as stated prior, on things to look out for and things to do if they experience some of these serious symptoms. And then towards the other end of the spectrum, things are getting more serious. Orange light versus red light. Where is our referral most appropriate? So that patient we think needs further testing, but do they need further testing as soon as they can get in to see a doctor, or do they need to go to the emergency room? That's kind of our decision making on this side of the spectrum. We're really picking up on some things that are indicating this patient may need treatment that we can't provide in PT. So identifying a referral pathway. These are individuals who we might be referring back to a primary care physician, neurologist, orthopedist, rheumatologist, or ER care. as applicable to the different conditions that we might be suspecting. Again, we're not diagnosing, we're not making medical diagnoses, but we could still make a specialized referral recommendation, assuming that patient is able to access that. Might mean going back to the primary care physician for a specialized referral. And so this slide is in here. This is in the Guide to Physical Therapy Practices put out by the APTA. And the reason I have this in here is, again, to reinforce the last stage of that decision tool is the referral decision. And within physical therapy, I think it's really important to remember that we are part of a multidisciplinary healthcare team. And so we are part of this team trying to manage and trying to deliver the best possible healthcare to our patient that we can. And part of that is communication process. So we need to feel comfortable communicating with referral sources, managing or co-managing with other individuals who the patient might be receiving care from, and really performing our duty within the screening process. As we'll go through in some of the case examples, sometimes we will get a referral and be working with a patient who's seen many other providers, or we will be referring that patient on to see further providers. And part of that communication process, I think, is doing our due diligence to communicate back to people that the patient has seen, but also communicate forward. So just remembering that we're part of this network to try to provide the best care. Okay, so let's talk through a patient case, and that'll kind of get us using this clinical decision tool and comfortable with the model. And before we get into the nitty-gritty of the different pathologies that we're going to be screening for in the lumbar spine, let's start by using this process a little bit. So I'll let you read this patient case study. I'm not going to read it for you. So take a second, you can pause the slideshow, read about this patient case, and then what I'd like you to try to do is work through the case with this tool. So what's your level of concern? Is it green? Are you picking up on any concerning features? What's your clinical decision? Are you going to treat or are you going to refer? And then who are you going to refer to if you refer? And is it urgent or emergent? So take a second, figure that out. What would be your decision there? All right. So based on the case, we see a few concerning features. So we do see a spreading of radicular symptoms from one lower extremity to two. That is concerning. That could be indicative of degenerating or progressing neurological deficits. We don't see bowel or bladder dysfunction. We don't see sexual dysfunction. As we'll talk about, those might be indicative of something more serious. So we see some maybe red flags. We don't see others. And because of this yellow area that we're placing the patient in, so that's our level of concern is yellow. Our treatment decision, or our treater referred decision, is to treat this patient and institute watchful waiting and safety net. If we do think a referral is necessary, if this patient isn't responding or if they are deteriorating, appropriate referral sources might be primary care physician, might be an orthopedist, might be a neurologist. So some discussion points from the case. Like I said, we do have this bilateral radicular symptoms or sciatica type symptoms, but no real bowel or bladder sexual dysfunction, no gait dysfunction. Neuroscreen is normal, which could further necessitate a more serious level of concern. And as we'll see, these different things that I'm highlighting are part of what we might think of as screening for cauda-equina syndrome. So bilateral sciatica is present. These other signs and symptoms are not. So that reduces our suspicion, though we do still have some suspicion. So we have to be prepared to refer if these things present themselves or if our suspicion is raised. So again, just to reinforce, this is a decision tool. This is our reasoning pathway that we're going to work through in these patient cases.